So we shall go on to our next speaker, Dr. Ashay Naika, who is a Victory Retina consultant from the Eye Foundation Group of Hospital, a very dynamic, highly charged, energetic, and also an innovative person he is. And it's been always a pleasure to work with him. And he would be talking on ultra wide field relevance in vascular occlusions and vasculitis. And Dr. Muna Bede would be discussing this.
At the outset, thank you, ma'am. Thank you, Chitra, ma'am, and Srinivas, sir, for providing me this wonderful opportunity. This presentation itself was quite a learning experience for me to look at this technique. So I'll be talking on ultra-wide field angiography relevance in vascular occlusion and vasculitis. I have no financial disclosures. So it is very evident that with the more pathology we decipher, in ultra-wide field, we get a lot of information where it makes us to arrive at more informed decisions to tackle our regular cases in vein occlusions. So the pertinent question which we were discussing previously is there a need to look beyond the posterior pole in retinal vein occlusions? So the main impact of ultra-wide field would be in studying this peripheral non-perfusion area, especially its effect on the risk of neovascularization and also its effect on macular edema. So this is a case of BRVO who had 6/6 vision. But on the angiography, we could see this large ischemic areas. So earlier with BO study, we knew that more than 5 disc areas would be ischemic BRVO. What I have done is taken the small disc size circle and fitted with the similar circles all around where there was capillary non-perfusion area. I could fit more than 50 disc areas. So this, as of now, there is no paper which says what is the risk of neovascularization. But this paper by Lip et al. Showed that if the disc areas is in the range of 5 to 354, with a median being 114, with a standard deviation of 80, all can give a risk of neovascularization. So, however, it doesn't make a concrete, give us a concrete definite number of what area is having more risk of neovascularization in BRVO. But it certainly gives 3 new angiographic patterns called the 3 Bs. That is the black retinal ischemia, which is seen in 100% of these cases, and the small budding retinal microvascular anomalies, and which is also seen in 100% of cases, and in at least 40% cases, which is associated with NVA at the border. So these 3 recurring patterns are also seen in, is been described by this paper. Another case where patient had large areas of retinal ischemia. Here also I have just tried to see how much I can fit disc areas, and I could easily fit around 120 disc areas. So the older definition of 10 disc diameters of non-perfusion is almost irrelevant now. And with ultra-wide field, it is very makes us easy to identify the CNP areas in a better way. And as we all know, less than 30 disc areas has low risk for neovascularization, and more than 75 disc areas has high risk for neovascularization. This paper by Nicholson et al. Showed that there is zero risk of neovascularization, zero in patients with 10 disc areas, and around 20% with 30 to 75 disc areas, and more than 80% in about 75 to 150 disc areas. But the most important point in this paper was about talking its relationship with the peripheral neovascular non-perfusion area and the posterior pole non-perfusion area. If the isolated non-perfusion area is more than 10 disc areas in the periphery, it had a very low disc area, very low risk of developing neovascularization. But if it was more than 10 disc areas of non-perfusion in the posterior pole itself, the risk was more than 85% for developing NV. neovascularization. So this is very evidently given in these two examples. See in this paper, in this example, the area is much less than the example 2, but since the posterior pole is involved, there is neovascularization. So with ultra-wide field angiography, the posterior pole non-perfusion of more than 10 disc area remains the key risk factor for the development of neovascularization. And another important indicator is ischemic index, which Su et al. Described and showed that it has a significant correlation with neovascularization, and eyes that had evidence of neovascularization had more than 45%. So, however, as we were previously discussing with targeted retinal photocoagulation, only Tomoyamatsu et al. Showed that it can reduce the amount of recurrent edema in BRVO. But this paper by Vinod Kumar et al. Showed that with ultra wide field, we can actually identify the neovascular area, which is in this case it has already been lasered, and by doing a targeted retinal laser, the patient was treated very adequately. So this case again, as was previously discussed, try to answer this significant question, that is whether a targeted retinal perfusion in the peripheral area, especially in ischemic CRVO, where patients were incomplete responders to previous anti-VEGF therapy, does that targeted retinal photocoagulation help to reduce the edema? But the answer was the role of targeted retinal photocoagulation was not did not have a conclusive benefit to reduce the burden of treatment of recalcitrant macular edema, and the severity of macular edema correlated well with the ischemic index of the entire retina and the perimacular area, and the reduction in macular area was correlated with the reduction in ischemic index of the entire retina, as well as the ischemic index of the near peripheral area and the perimacular area. So this case this paper by Nicholson et al. Also showed that as the with ultra wide field angiography, it was correlated that more than 10 disc areas of the posterior pole of retinal capillary non-perfusion was associated with large peripheral non-perfusion area, and the risk of anterior segment neovascularization is not abolished by using concomitant anti-VEGF therapy. So primarily they say if the posterior pole disc area of more than 10 disc areas are there, then the peripheral ischemia will also be significant and can also cause anterior segment neovascularization. And the fellow eye also is very important, because this paper showed 11% involvement of when the fellow eye with peripheral vascular leakage, which was associated due to hypertension or higher load of inflammatory markers, inflammatory cells, and as well as undiagnosed bilaterality. So ultra wide field Octa is also is coming of age, but it doesn't give other than showing the microaneurysms, retinal microvascular abnormalities. It doesn't add much to the treatment. In coming to vasculitis, ultra wide field has a great advantage because it helps in identifying the disease activity, which will help in changing management. And this is very evident by this paper, where it showed that only with examination disease activity was seen in around 38%, but with ultra wide field imaging they were able to see the activity in almost 67.6%. So this paper by N.P. Jones identified almost 58% of their patients with which was there outside this 7-8 EDRS fields, and 20% of the patients were purely treated on the basis of ultra wide field imaging. This is a case with SLE who had 20/20 vision. And the posterior pole had not much activity, but with ultra wide field, the peripheral areas had phlebitis, and it is outside the 7 field of ETDRS chart. So this is another case which had absolutely normal vision with SLE vasculitis, and on peripheral examination, there was a neovascularization. The patient was already treated with laser, and more laser was added to manage this case. So this paper by Vinod Kumar et al. Used ultra-wide field imaging in Eales disease, and which they concluded that it was helpful in documentation of peripheral retinal changes in 60% of their eyes, and the exact location of capillary non-perfusion was seen made out in 54% of the eyes, and
You have 1 minute remaining, sir.
And in determination of vascular network in 21% of the eyes. So in 30% of the eyes, they were able to revise the treatment immediately. In this patient, already lasered, there was neovascularization, they immediately lasered, and the neovascularization quietened down. This paper by Chaudhary et al. In 2019 came with a consensus about wide field imaging, and based on the Optos gives around 200 degrees, but now with this they based it on the anatomical landmarks, and also told wide field images can be montaged to create ultra wide field view. Basically, the information is already there. Ultra wide field will give us in a single picture, and not many of us have an access to this wonderful tool which can be used in our daily practice. So how can we achieve ultra wide field in our daily practice is something which all my friends keep asking, and to give it an answer, I suggest we should all use this new open source software called AutoStitch. People who are interested can download from this link. And this is one paper where with this software, these 8 pictures were seamlessly stitched to give a wide field imaging, and it can be used. It does not give you a very large Mercator projection artifact, which is already seen in other montage softwares, and it's absolutely free, and everyone can use it, and everyone can use the magic of ultra wide field imaging to treat their patients. Thank you.
Very good. Excellent talk, Dr. Ashray, and very well covered. And we look forward to the discussion. Dr. Muna.
Yeah, thank you, Ashray. That was a very nice talk. And I think you covered most of the applications of ultra-wide field imaging in vasculitis and vein occlusions. We all agree that it's quite contentious whether we would treat macular edema based on what ischemia you see in the periphery. But I would agree that ultra-wide field is important when you have patients where you think you have treated adequately. Patient is having rubiosis, repeated rebleeds. So those situations definitely it helps, especially in a patient with a CRV. A little clue or a warning when we rely only on ultra-wide field, especially in cases with vasculitis. Sometimes we tend to miss finer points of the disc and the posterior pole because we are so interested in the periphery. I would suggest that magnify it. If you're using a Heidelberg, take a couple of 30-degree views somewhere in the middle of the angiogram so that you know that you're not missing neovascularization of the disc and thinking it is disc leak, because I have known that to happen. Whereas with the new California Optos, you can magnify any picture and it doesn't lose its resolution. So I think that's just 2 points that I thought I would tell you that we can use. And Heidelberg has the auto montage facility, so you can get, you needn't use an external software.
Thank you very much.